It's an honor to be with my idol, Gordon Christensen, the god of dentistry, in downtown New York City at the, where are we at? The Grand Hyatt?
Grand Hyatt. Yes,
at the 11th Annual MegaGen Convention.
Right on.
And great to see you again.
My pleasure.
So, Gordon, you were the first person that ever talked to me about implants on one of your 2-day weekend courses in Provo, Utah. 25 years ago, I was up there with Totolo. We went up there 2 days every month for a year.
Right.
How have implants changed from when I first met you 25 years ago to now?
Unbelievable change, Howard. What we've had is simplicity that's been instituted by many, many companies, as you know, and the cost has lowered dramatically, although there are still some that are running as high as $600 and $700 for all the accoutrements that go with an implant. There are some that are low to medium cost that are equal in quality and easy to use, with good service and with education.
So they've. Do you think when I first met you, all the X-rays were 2D? Now it's going to 3D. The cone beam technology. Do you think that's a game changer?
The program I'll give this morning will indicate. I had 25 years of no cone beam. I've now had 13 years with cone beam. I would never go back. I see things daily that I've never seen before. I'm able to judge quantity of bone, facial-lingual quality of bone, able to make predictions as to whether or not an implant's actually going to work, where before you were just lucky to find the bone.
Right. I remember sometimes we'd think we had an inch of bone on the pano. We'd flap it back and just this little knife edge thing. And
right on.
By the time you smooth it down to get 5 millimeters of width, you didn't have any bone. Gordon, one of the problems for general dentists is you want a cone beam that will find a fourth or fifth canal in a molar, yet you want one for an implant, and you might even do a little ortho. Is there a cone beam technology that could find a... well, first of all, let's go to endo, because far more dentists do root canals than place implants.
Yeah.
What cone beam could find an MB2 or a missed canal?
Okay. I started out with Planmeca 13 years ago, and then there was some competition, not a lot. And over that period of time, now we have many, many companies. Shine, Patterson, Benco, Burkhart, Getsy. The time you add them all together, you have 20 or 25 devices. And there's differences night and day. If you take little periapical radiographic sensors, they're 6 of one, half a dozen the other, and they're all too thick and they're all miserable to use. They don't show initial caries. If you go into cone beam, however, they're very, very different. Some have higher radiation, some lower radiation, some will have 2 images you can do, some will have as high as 9 images you can make, different small or larger segments. I still find myself going to Planmeca fairly often because it has 2 major softwares. One will do a very fine pan for me. One will do the 3D. But yet there are some others highly competitive. The South Korean brand, since we're in a South Korean company here, South Korean brand Vatek is...
How do you spell Vatek?
V-A-T-E-C-K.
V-A-T-E...
Vatek.
Vatek, okay. That's a South Korean?
That's one of the most popular ones in the world. In America, ICAT is the most popular. Sorona about second. Third would be probably Planmeca. Fourth would be Gendex. So you've got a whole milieu of those, but they're like a sports car and a SUV.
I know you didn't mention Carestream.
Well, Carestream, I've got Carestream in right now. What we're doing, I have one major one that I use all the time, and we do cone beams for the community where I live. But we also have these consignment items that come in, so it's easy to compare. We have Carestream right now, low radiation, easy to use, 2 major devices, a higher level, a lower level. The lower level serves most general dentists very adequately. The higher level for oral surgeons.
You mentioned Planmeca out of Helsinki, Finland. They just bought E4D out of Dallas.
Right on.
Is that going to be a game changer?
Oh, absolutely, yeah, because there's obviously financial resource there and lots of engineering capability. It's interesting to note, though, over all the years I've been associated with the various Scandinavian countries, I've never seen a sober Finn. So I wondered, how the heck they made that sophisticated device. It really is excellent.
Is that right?
Yeah.
Are they heavy drinkers up there in Scandinavia?
Yeah.
I think it's funny when Americans, you ever hear all these redneck Americans that are against like socialism, they've never left the state, because whenever they talk about socialism, it's always Scandinavia, it's always Denmark, Sweden, Finland, and Norway, and I think those are the nicest societies in the world.
That's my heritage, Denmark.
Yeah, I mean, you go to these countries like, really, this is the bad socialism? Like, this is the greatest society ever. Hey, Gordon, I want to ask you specifically about this new Denton grinder.
Yes.
Because when I saw this, the Denton grinder is this new thing where for bone grafting, you throw the extracted tooth and grind it up. But I swear, when I saw that, I had a flashback to you 25 years ago saying that there's coral in the ocean that's a billion years older than human hydroxyapatite.
Yeah.
Will we be throwing coral in that thing someday, or what do you think?
When I saw this first, it was about, would have been a year ago at the Greater New York meeting. And this is obviously an Israeli invention. And I thought, why didn't I have that idea? And then we took it back to Clinicians Report, and we have several who are now using the thing, several of our evaluators, and so far, so good. My initial thought on the device, which is very simple. It's a grinding machine with that you throw away the actual grinder, and you keep the motor, and you're taking both enamel and dentin, and whatever cementum might be left on there, grinding it up, and then dissolving off any organic crud that might, pulp and periodontal ligament that's still remaining and so forth, and then subsequently filtering it out and sticking it back in. And one tooth creates about 3 times the volume that it appeared to be, because obviously you got spaces between the little ground up particles. And for $40, give or take, which is about the cost of the grinder device, the top part of the grinder device that you're looking at there, the top part you throw away, the bottom part you keep. I'm not here
Why is it one-time use?
Apparently because it'd be contaminated enough that it'd be difficult for using it on another patient.
To autoclave it?
No. So I'm not particularly promoting it at this time. We just have it out in preliminary use. We've had a couple of our evaluators have had 6 months of successful use with it. So we'll keep watching. And to answer your question, how many other things are hydroxylapatite? Oyster shells? I don't even know all the things that could possibly be similar. Rather than $100 for a little bit about the end of my little finger, that's about what we're paying for a bunch of ground up dead guys'
now,
leg.
Is it true that the idea for this came when someone was watching the last scene of the movie Fargo? Is that
Who
true?
knows? Who knows, Howard?
Do you remember that movie? But what is the low hanging? What would you? This is the end of April. Next month, 5,000 American kids will walk out of dental school. What would you say to them about the future of? I mean, should they get into? Should they be thinking that someday they'll be placing implants? and if they were going to, what percent of the dentists think place implants now? About 10%.
It's not even 10. Now, this week I've had 4 speaking events, and I've asked that question in each one, and I'll get 2 or 3 feeble hands that will go up in a huge group. I had 900 recently, and I won't mention the state because it would embarrass them. In 900, I had half dozen. Now, here's a good example.
First of all, why is that, do you think?
Why is that? We're very behind other developed countries. A lot of the developed countries I get into, it'll be 75, 80% of dentists. I was in Israel a while ago. It was somewhere in that ballpark. It's because we have turf battles abounding here that make some feel superior to others. We did a survey about a year ago of thousands of dentists to see how difficult a single implant in a healthy person with good bone. Qualified that now, and that's 90% of implants. Healthy person, good bone, single implant. We found, as they compared it with the other over 100 techniques in dentistry, that it compared very, very equally to a Class 2 composite.
And placing an implant.
Yeah, why? So somebody would not do an implant, but will take on a huge Class 2 composite with sensitivity, contact areas,
now,
color, margins, and so forth.
So a lot of people listen to that are calling blood. They're saying, Gordon, did you just say that placing an implant is the same difficulty as a Class 2 composite?
That's right.
Now, are you qualifying that because you're talking about a CBCT to make a surgical guide? So
No.
So explain how placing an implant could be the same
let's say it's a first premolar. Let's make it even easier. Second premolar, one root. Okay, and the bone is not the parallel with the sagittal plane of the head. It's slightly inclined, isn't it? 15 degrees, give or take. Okay, so out comes the tooth, and if they can't do that, it's time to sell shoes or something else. There's nothing particularly problematic about that. So that now they got a hole. Are they going to graft it or not graft it? And that's what I'm going to go into in just a minute. Obviously, there's good research saying you don't have to graft it. You can go ahead and stick something in the hole right there. Then once they've found it, they're going to go between the two teeth. How hard was that? This one and this one go down the middle. Now they're going to have to look at the facial and the lingual, go down the middle. Do I need a $400 to $1,000 guide to do that? I think not. In fact, it really irritates me that the companies continue to push. We got to guide this. Well, geez, years ago they had guidance for crown preps. It took longer to put the guidance on than to do the crown prep. If they've had a lot of experience doing crowns and paralleling things, how hard is it? Go between the teeth, go between the bone. Single implant, healthy person, good bone, slam dunk, 20 minutes.
I agree. And I think if the dentist can't do it or feels nervous about it, they should have their assistant do the first 10 while you just watch. And, but Gordon, back to the graduates, our opinion.
Okay.
So, I mean, do you think the 5,000 graduates have quality implant training? I mean, do you think they're ready to?
Zero, sub minus, inadequate.
So these 5,000 graduates, if they want to do what you just said, give them a pathway. Do they need a CBCT to do this? They're coming out with $250,000 student loans. Yeah. Do they need a $100,000 cone beam?
They need access to it. In our own facility, we have 2 cone beams at any one time, and we do cone beams for the community. They can come in. They will get a cone beam done for about half the price of a normal clinical exam with a cone beam. I don't interpret it, although we do give courses on how to read cone beam. I do it with Dale Miles, oral and maxillofacial radiologist. They need access to it. Find a little community clinic who's got a cone beam and pay them a half or so of the normal clinical fee and go for it.
What percent, if you're a practicing dentist, what percent do you think of your area specialists like periodontists and oral surgeons and orthodontists would let you take a cone beam for your patient? What percent of them? If this young dentist came out of school and started practicing.
Oh, I see what you mean. I'm thinking more along the lines of a radiographic clinic. You may remember I had panoramic clinic for 40 years, so everybody had panoramic. I think we're going through the same thing right now with cone beam. We will have, I'm going to guess, 5 to 10 years when very few have cone beam, and then slowly it's going to grow as they go down in price and people get more involved with cone beam.
Well, I know in my backyard in Phoenix, I don't know a single periodontist with a cone beam that if a general dentist sends a patient over there, they won't take one for them.
Yeah, sure.
You know,
sure.
So you're saying you just need access to cone beam. But again, more specific with that graduate, how does a graduate graduating next month in May get to placing an implant on number 2? What baby steps?
Now I'm going to irritate some of the people listening to this thing. If they can't, in a couple or 3 days, learn how to put a single implant in a healthy person with good bone, it is literally hopeless. Go back to doing Class 1 amalgams. I think it's that simple. Getting out of school, however.
So you're saying a 2 or 3 day course?
We have two levels of courses.
Okay, well, specifically talk about those.
The first level, of course, is how to put small diameter implants, which talk about simple.
Mini implants.
Yeah, small. That would be 1.8 to 2.9 millimeters in diameter, and that in one day they can do that. The second day we go healthy persons with good bone. So in 2 days now, they've got very rudimentary knowledge about it. They can do it on dentiforms. They haven't done it yet on people. I suggest they go to the local slaughterhouse and get a cow head or a pig head, slash the lower jaw off, which we actually do in one of the courses, and start boring holes in that bone, or go to the grocery store and get some cow ribs and start boring holes in those, and get some slug implants from any one of the companies. Not the real implant, but ones that are mimicked, and start screwing them in the bone. The only difference when they jump to a patient is there's blood, and they got to anesthetize it. Now, the next course we give goes into sinus lift, it goes into socket grafting, and the various things that are related to a little more advanced technique. Many don't want to go there.
Do I have some more time with Gordon, or are you trying to take him away? How much?
Maybe 10 minutes.
Okay, 10 more minutes?
Okay.
And Gordon, how does a listener find out information about these? What website would they go to find out about your implant courses?
P like Paul, C like cat, pccdental.com.
For practical clinical courses?
Practical clinical courses. pccdental.com. And they're 2-day courses. There are 2 of them on implants. And then we have another one called Christensen Comprehensive. That's another 2 days that puts together a lot of treatment planning. They bring in their own cases. We look at them, make them do the treatment plan, and go from there. So there are really 2 that are surgically oriented and 1 that's more restorative oriented.
And by the way, me and my buddy Mike Totola, you know Mike Totola, we both think that going to a 2-day course once a month for a year at the very beginning of our career skyrocketed us 5 years ahead. I mean, it was just I don't think there was a way to blast yourself.
We enjoyed having you there.
So Doc, in this is 2015. In 10 years, do you think it will still only be 10% of less dentists placing implants, or do you think
I've been
these
hammering
graduates are going to be different?
on it now for 20 years, saying, general dentist, wake up, do this. I did it as recently as yesterday in a big meeting, and it's just hard to get them to go that way, because there's been so much turf fight. Oral surgeons are the only ones smart enough to do it. Periodontists are not quite as smart, but they can do it. Prosthodontists, myself, we're dumber than a rock. General dentists can't even count to 10. You see, there's that hierarchy that is impeding it enormously. One of my kids practices in Canada. He'll do everything from brain surgery to circumcision, and he's a general dentist. You know what I'm saying?
Yeah.
But you get somebody in a big city, like it was yesterday, in a big city, there's that hierarchy that exists. I've even seen some, and I hate to be hard on any surgical specialist, but they'll want to take out the implants that have been done by some general dentist. Yes, the turf battles will abound forever, I think.
We're here at the MegaGen. I lectured yesterday, your lecture day. I got turned on to MegaGen by my very good friend Jerome Smith. Mm-hmm. He's a hardcore MegaGen fan. What do you think about MegaGen?
MegaGen is a company that's attempting to do just what we're talking about, and that is here's my strong feeling. I would like to see every general dentist who's not afraid of blood be able to put a single implant in a healthy person with good bone. If he does, or she does, that is 90% of implants. 90% are singles. Where you see cases where they're all on 4, or I did all on 6 for 20 years, but that's a few people. That's people making $200,000 and $300,000 a year to even be able to do it. When you come down to the normal person in a typical town, in a typical general practice with a family making $54,000 a year, the whole family, they're not going to afford a $20,000, a $30,000 thing. They don't want to. But they will afford 2 implants there, or 1 here. Even ADA says we ought to be putting 2 single implants in a mandibular as our primary treatment plan, as you know. And I'll expand that to 4 little ones. So either if there's not enough bone, 4 little ones. If there is enough bone, 2 big ones. And that's $5,000. Anybody can afford $5,000 if they are making that $50,000 a year, $54,000.
And what I'm hearing Gordon say is what Henry Ford said: if you focus on the classes, you'll beat poverty and eat with the masses. If you focus on the masses, you're going to be rich and eat with the classes. And isn't also, so you're saying basically 95% of crowns are done one at a time.
Yep, right
you're
on.
saying 95% of implants are
They
done
are definitely
one at a
done
time.
that way. We need implants for the people, not for the dentists.
Yeah. So
I really mean what I just said there. 97% of them can't afford half of the stuff we talk about in implants. And the other 3% can, and that's the hobby dentistry. The real dentistry is for the people, and that's these simple things.
So Gordon, you're saying 90% of implants, healthy patient, healthy bone.
Yeah.
I would think a lot of people are listening, thinking, well, no, most people lose their teeth because they're severe gum disease, diabetes.
Mm-hmm.
So why are you saying 90% of teeth lost that need implants are healthy bone?
Well, as you know, the data the data on periodontal disease and subsequent healthy implants is still a moot point, still controversial. Nobody has really said you can get on the meta-analysis both sides of that a person with perio is going to have bad implant health. Once the teeth are out, it appears that the bone is still going to be adequate to hold an implant. So it doesn't really relate, as you might think.
Because there's a difference in periodontal disease around a tooth with cementum.
Yeah.
Versus the perioorganisms around implant.
Very different. Very different.
Is it very different? Is the periimplantitis, can it be as aggressive as the periodontal disease? Or
no. And I have a strong theory there that really needs to be followed out that I've not had the time, interest, or energy or money to do. And that is we're seeing titanium allergies. And that's the thing that's trying to get people into zirconia implants. And I'm not pushing zirconia implants, but I'm saying a lot of people will say, you got periimplantitis, when in fact you go on any website that's evaluating leukocyte changes and so forth, you'll see anywhere between 3 and 30% sensitivity to titanium. Periimplantitis may have nothing to do with organisms. And I know I'm out in left field according to the period.
No, you explained it to me very well 30 years ago that, some people can put on a base metal ring and fine. Others will get a green tattooing.
Right on. I think we're dealing with that with implants. The few where somebody will apparently scientifically say, oh, periimplantitis, put some chlorhexidine, put some Arrestin in there, do something exotic to it, when in fact it's probably an allergy to titanium, vanadium, or aluminum. And that's what we got in an implant.
And you see it with the braces, where some kids get on braces and the gums go crazy.
Mm-hmm. Yeah.
Take out the brace and it goes
Right
away.
on.
So how much more time do I get him? Am I out of time?
We might want to.
We're out of time. Hey, Gordon,
we're
I just want to end with saying, seriously, from the bottom of my heart, of almost every dentist I know, if I said, name the person who's your role model, your idol, who took you from the beginning to the top, probably 99% of the times they say it was Gordon Christensen, the god of dentistry.
Thank you.
Thank you for all you've done for
Thanks
dentistry.
for all you're doing. My gosh, you've influenced more people than any.
I'm not a
dentists.
rounding error on what you've done for dentistry.